Okay, I think we're live. Is that right?
Yeah, I can
we're
hear
live.
you.
Yeah. Hi, everyone. Welcome to another webinar of our FY1 Survival Guide. Today's talk will be about the ePortfolio, and it will be delivered by my colleague, Dr. Nihal Chanian, a doctor working in the West Midlands Deanery. I'll be available in the chat to answer any questions throughout this talk, but more importantly, we'll have a Q&A session at the end. Don't forget to fill out the feedback forms at the end of this talk to get a certificate for your portfolio, and this can also be used as a non-core teaching hour for your FY1 year. Thank you. So without further ado, I'll hand you over to my colleague, Dr. Nihal Chanian.
Thank you, Hamza. Just checking, can you hear me?
Yeah, I can hear you.
Perfect. So, hi guys, I'm Dr. Nihal Chanian. I'm one of the doctors in the West. Thanks, Hamza, for introducing me. Today's talk's on understanding the ePortfolio, and it's our 6th webinar in our FY1 Survival Guide series. This is a 10-part series teaching you guys about some of the fundamentals and important things you need to know before starting FY1. So without further ado, let's start. In terms of the contents of this session, first I'll introduce you to what a portfolio is. Okay, we'll go through the main requirements of the FY1 portfolio. We'll discuss the different types of supervised learning events and how many you need to aim to complete in a year. I'll go through my ePortfolio, which will hopefully let you visualize things a little bit easier. And at the end, we'll just summarize some top tips I have for getting your portfolio done and sorted so that you can pass your ARCP. So just an introduction, the ePortfolio is a record of your clinical competencies, learning and progress during your training in your foundation year. Completion is essential to pass your annual review of clinical competencies. This is also known as your ARCP. And there are two main platforms used within the UK. So Horus is used in England and parts of Scotland, Northern Ireland and Wales, but not all. And Turas is used in Scotland, Northern Ireland and Wales. I'll be focusing on Horus because I'm based in the West Midlands in England, but everything I'm saying is transferable and can be used if you are working in one of the other countries and on the other platform. So let's go through the main requirements of your FY1 year. So at the beginning of each placement, you'll need to arrange an initial meeting with your clinical supervisor, an initial meeting with your educational supervisor, and you need to complete a personal development plan, also known as a PDP, before you have these meetings. In your PDP, you need to state your aims and objectives of your rotation. So you've got 3 rotations. You need to complete 3 PDPs, and they have to occur before your initial meetings. In terms of arranging your initial meeting, it's worth sending your supervisors an email. If you can't get through after a week or 2, send another email. And finally, if that fails, as has happened with me and a few of my colleagues, because the consultants are very busy, it's probably worth speaking to the secretary and trying to go through them to arrange a meeting with your supervisor. And remember, guys, it's on you to arrange these meetings. So if they're not arranged, essentially that will be your fault and not the fault of your supervisor. As a last resort, if you can't get a meeting, I'd recommend contacting your foundation program director. There'll be one based locally in your trust, and they can often help you with things like this. In terms of your main requirements throughout each placement, you need to complete mini KEXs. I'm sure you're all aware of these. Case-based discussions, direct observations of procedural skills, also known as DOPSs, and a number of reflections. As per the new 2021-2022 curriculum, you no longer need to complete something known as core procedures. So that was a number of procedures that you needed to complete. I think there was a set minimum number for each of the procedures old FY1s had to complete, but we don't have to do that anymore. In addition, there is no mandatory minimum requirement for SLEs or supervised learning events. However, the UKFP suggests to aim for about 15 to 20 a year, I think this year I did about 20 and that was fine. So yeah, aim for about 20, slightly above the minimum, and you should be good. And part 3, at the end of each placement, again, you need to have meetings with your clinical supervisor and your educational supervisor. It's worth noting that with your educational supervisor, your end of rotation meeting can overlap with your start of your second rotation meeting and so forth. So you can sort of do a 2-in-1, and most deaneries are happy with this. So instead of doing 6 meetings, you only have to arrange 4, which makes things a lot easier. Now you also need to complete a summary care narrative. We'll go into this a bit later because it's quite complicated, and it took me a while to figure out how to do it. But essentially, a summary care narrative explains why the things you do within your year map to the curriculum that HEE and UKFP have designed for you. So, for example, I've done a case-based discussion on a psychiatric patient. One of the curriculum points in our curriculum is based on assessing the psychological needs of patients. So I would then map that SLE, that CBD, to that curriculum point. And in the summary care narrative section, I would write why it's relevant. So in my case-based discussion, we assess the psychological needs of this patient by doing this, etc., etc. Generally, throughout the year, there are a number of things you need to get done. Okay, so the first thing is a team assessment of behaviour, also known as a TAB. For this, you need to get 10 responses from members of the multidisciplinary team. This can include doctors, nurses, pharmacists, colleagues, or anyone else who's based within the MDT. It's worth noting, though, that you can only have a certain number of doctors, and you do need to get some consultants to fill it out as well, which is a bit difficult, but you'll come to learn about that. You also need to complete a placement supervision group, also known as a PSG. This is something that your clinical supervisor will send. It's not something that you will send to people. By the way, yeah, with the TAB, it's the same thing. You will send an email link to someone and ask them to fill out some questions about you, like, are you a good member of the team? Do you pull your weight, etc. Same with the PSG. The clinical supervisor will send emails to certain members of the team and ask, were they a good colleague? Were they meeting the objectives that they should be meeting, essentially? You only need to complete one of each per year, and you can only do them in one rotation. So if I get 6 responses from my TAB in my first rotation, and I need 10 responses totally, those 6 responses can't carry over to the next rotation. You need to get all of your responses done within your one rotation. So in theory, if I got 10 responses in my first rotation, TAB complete, I don't need to do one in my second or third rotation. Similarly with the PSG, there is no minimum number of assessors, unlike the TAB, but try and aim for 3 to 4. Okay, and if you haven't got 3 to 4, check in with your clinical supervisor, who can send more emails out to team members. It's worth noting as well, if you can't get these done, just dropping your team members a little message to say, would you mind spending 2 minutes of your time to fill out one of these for me? It's required for my progression. And most people are happy to help. You also need to complete your PSA. I know some of you will have completed this in your final year of medical school. If you've trained abroad, then you probably won't have completed it, and you'll need to complete it while you're here. You can prescribe without completing the PSA, but you cannot progress to FY2 unless you've passed the PSA. So that's probably one of the most important things to get when you're in FY1. I think you get 3 attempts. So if you don't manage to pass in one of those attempts, you will have to resit the year. You also need to complete an audit or a QIP, also known as Quality Improvement Project. You only need to complete 1 cycle of each. Okay, so you know what an audit is. You have a set standard, and you're trying to assess whether the department meets those standards. So, for example, I completed an audit for the radiology department, the radiology and emergency department, assessing whether they'd met the NICE 2019 criteria for requesting trauma CT head scans. So there's a certain checklist you have to fill out before requesting a trauma CT head scan. And I just assessed the performance of the departments against that, and that counted for me. You also need to complete something called a Form R. This is something where you have to declare things like your amount of sick leave in your year, if you've taken any locum shifts. I think for sick leave, you can do a maximum of 20 sick days before you have to extend your FY1. So it's worth noting that if you are sick for a prolonged period throughout the year, contact your clinical supervisor, contact your education department and or occupational health, and see if they can help you with those things. But if you do go past 20 days, unless your portfolio is absolutely stellar, they'll most likely make you resit a few weeks of F1 just to iron those things out. But yeah, the Form R is sort of a administrative thing that you complete at the end of the year just to sum everything up. Throughout the year, you'll also need to complete 60 hours of teaching. 30 of these hours must be core teaching. Core teaching means it's been organised by your local education department. Oftentimes, you'll need to sign a register or sign in via Teams. That will give proof of attendance. For non-core hours, you can do things such as e-learning, although note there's a maximum of 6 hours of e-learning which you can do. E-learning is classed as something where you just click through a series of slides or whatever. So like e-learning for health modules. You can do those things, but you can only log them as for a maximum of 6 hours of your non-core teaching hours. Online webinars or courses you've attended count as non-core teaching, so make sure to log those, especially if you've attended a seminar that's lasted all day. That's 8 hours of non-core teaching. So by the end of the year, it should be okay in terms of logging 60 hours. I think in the end I logged about 75, and I wasn't really going hard to try and get the teaching hours in. So it's not too bad. Just make sure to stay on top of things and attend core teaching when you can. I know that in certain deaneries or departments, you are meant to go to your core teaching, and you do have allocated time in the rota to go to your core teaching. If you're not getting the time to go to that, you need to raise it with your education department, because it's on you again to meet your core teaching hours, and your department should be letting you go to do this. Okay. In terms of supervised learning events, there's 6 different types. The main 3 are mini-KEXs, DOPS, and CBDs. Mini-KEX means direct observation of the foundation doctor undertaking an interaction. So that can be anything. That can be a history, that can be a clerking, that can be an examination, that can be breaking bad news, for example. Okay, that can be anything, but it has to be directly observed for you to complete that. DOPS, again, directly observed, and that is a procedural skill. So for me, some of the DOPS I managed to complete were ultrasound-guided cannulas, difficult ABGs, so like brachial artery ABGs. In my anaesthetics block, I intubated a few patients and got those signed off as DOPS. But yeah, anything sort of procedural counts as a DOPS, including cannulas and ABGs. But try and get a variety if you can. I know one of my colleagues worked in the gastro department, and he was able to get a number of gastro procedures signed off, like drains and so forth. So it does vary from department to department what sort of things you can get done, but it's always good to get that experience and get it signed off by one of your seniors. You can also do something called a CBD, which you've all probably heard of, case-based discussions, and those interactions with the patients can be unobserved as long as you've discussed with the consultant or senior afterwards. A good time to do your CBDs is while you're on call. So during my medical block, I was in AMU for my first rotation. During the daytime on-call shifts, I'd often clerk a patient in, and the on-call consultant would come and discuss that patient with me. And I just introduce to them and say, would you mind we do this as a CBD? And more often than not, if they're not too busy, they're happy to go through it with us as a CBD with you. So yeah, make sure to always introduce when you introduce the case to the consultant or the senior and directly state you want to do it as a CBD. Otherwise, they might feel a bit blindsided if you go through the whole presentation of the patient, don't really discuss it, and ask to be signed off as a CBD at the end. Some other SLEs, so there's something called Learn, which is Learning, Encounter and Reflection Note. I'm going to be honest, I've not completed one of these, and I'm not sure if any of my colleagues have, but it's something you can do if you get the opportunity. So an example I've read from UKFP is Observation of Performance in Simulation. There is 1 or 2 simulation days you have to attend while in F1. Your deanery will organise it. We often get certificates for those, so I'm not sure if a senior will fill out a Learn form, but if that's available in your deanery, go for it. There's a Teaching Others form, and that has to be feedback for a formal teaching session. So if you deliver departmental teaching, for example, you can get a consultant to sign off this form, as long as they're aware that you've been teaching others. Informal teaching via the bedside won't count for the Teaching Others form, but you can get it done for you can log informal teaching for other things, and I'll go through that with you in a moment. You can also complete a leader form, so that's feedback from a senior after the foundation doctor has demonstrated leadership skills. So any kind of leadership, if you've been the F1 rep, if you've been the mess president for your hospital, for example, you can get one of your seniors to fill out a leader form, sign that off and log it within your portfolio, which you can then map to your curriculum, which will look really good. There are some additional achievements you can do during your year. So if you've passed any exams like ALS or MRCS Part A, if you want to do surgery, those can be logged in the additional achievements section. Just a note with ALS, it used to be a mandatory requirement during foundation year training to complete this to progress, but I think that's been removed now. So it is good to get your ALS done, because if you're attending cardiac arrests, you want to know how things work and how you can be of help, but it's not mandatory. Similarly, with any courses or seminars attended, such as basic surgical skills, you can log that as an additional achievement and map it to your curriculum. You can log any interesting cases, any publications you've completed, any taster weeks, as well as any informal evidence of teaching. And just a note with the taster weeks, during your FY1 year, you get a maximum of 5 taster days, which is classed as 1 taster week. I think 1 taster week is actually classed as 3 days, but you get 5 taster days where you're allowed to go to any department you want, as long as you arrange it, and you have that time off of work. So, for example, I completed a radiology taster week. I spent 3 days in my radiology department, got my consultant to write me a letter to confirm I'd completed a taster week, and I mapped that on the taster week form and added his email in, and he was happy to sign me off for a taster week. Again, informal evidence of teaching can be logged as well, such as bedside teaching. You just fill in the form, and it doesn't have to be signed by a consultant, as long as you can give some form of evidence, such as informal feedback on a Word document or something. Just a note on mapping, because this is what confused me and a lot of foundation doctors at the start of FY1. There are 15 foundation program capabilities, also known as FPCs. Think of these as curriculum points. So 15 things on the curriculum, broadly speaking. You can map anything you do throughout the year, teaching sessions, SLEs, e-learning, reflections, any sort of form. You can map it to the curriculum, and that will count as meeting your curriculum objective, as long as it's outlined in the description, which we'll go through. But yeah, you can map a maximum of 10 items to each FPC, totaling a maximum of 150 mappings throughout the year. My department told me, or my hospital, told me to aim for a minimum of 100 mappings. That's what they would like to see to pass FY1. So I'm not sure if it varies from deanery to deanery, but where I work, they asked me to aim for about 100 mappings. I think in the end I got about 125 or 130. But it's good to map as many things as possible, just so you can show you've been working hard on your portfolio and that you're going to pass FY1. Okay, I'm going to take you through my ePortfolio now. I work on Horus ePortfolio. So I'll just take you there a second. Yeah, so this is my portfolio, okay? It's Horus. It's got my name there. It's by Health Education England. This is the contents page, okay? So here it's got my placements: acute internal medicine, anesthetics, and general surgery. Here we've got a list of sort of what I've done in my rotation one. Oh, that's for the whole year. So, yeah, we've got the different form types on the left. So courses, seminars, other two evidences of quality improvement projects, a taster week, and 2 teaching others forms. I'll just scroll down. Got an ARCP outcome form, a form R which I completed at the end of the year, again detailing any absences or locum shifts I've taken up. I think with the locum shifts, they do want to know if you've been working lots of locum shifts, because if you're working less than full time, for example, if you're working a lot of locum shifts to supplement your income, it might be sort of they might not like that essentially, and they might say if you're working locum shifts while on less than full time, you can work full time for less pay. So yeah, it's a difficult one. So with the locums, you have to declare them legally. Again, you have to legally declare your absence as well. So it's something just to be aware of. There's a career planning section, mandatory certificate, which is my PSA, 3 PDPs, 1 PSG summary, 18 reflections, my list of all my meetings. I told you again, I did 20 CVDs and my end of placement reports, as well as my tab. And all these blue icons here means I've been mapping it to some curriculum. So if we go to the top, my PSA, mandatory certificate, I have mapped it to the curriculum. Which part have I mapped it to? I think here. Communication and care, provide clear explanations to patients, deliver healthcare advice and treatment where appropriate. Continuity of care, contribute to safe ongoing care both in and out of hours. And I'll show you why I've mapped it to those sections a bit later on. This exclamation mark here is just when you've sent it to a senior but they've not signed it off yet. Because remember, most of these forms have to be signed off. And yeah, that's everything for that page. So I'll just go to the curriculum. Here we go. So this here, I'm pointing at it with my arrow, that is FPC1. There's 15 FPCs. This is the evidence I've mapped to FPC1. I'll show you the descriptions for each of them. So this is FPC1. Assess patient needs in a variety of clinical settings, including acute, non-acute, and community. And these are the things you need to demonstrate within FPC1. So communicating with patients sensitively and compassionately to assess their physical, psychological, and social needs. Again, for this you can map a CBD of a history or an examination. Understanding that presentation, including some physical signs, will vary in patients of different backgrounds. Uses collateral history and alternative sources of information where appropriate. Examines physical and mental state of patients sensitively, with a chaperone if necessary, including in interpreting clinical signs elicited by the mental state examination, and recognizing vulnerable individuals, including those at risk of abuse and exploitation. So here you can see I've done some things which map to these behaviours. I've got an e-learning for health module which I've completed on the mental health examination. That maps to this one. I've got a let's have a look. Yeah, again, psychotic disorders, psychiatric statement, and I've got mental health act. I've also got, I think, a course, seminar, other learning attended. I think that was, yeah, here you go. Safeguarding learning. So again, that maps to that bottom point here, recognizing vulnerable individuals, including those at risk of abuse or exploitation. So you can see how it all works. the things you need to do are complete your SLEs, complete your teaching, and then map it to your curriculum. And there's these things here called summary care narratives, where you explain why you've mapped the things you've done to those behaviors. So I'll show you how I completed it. Here is an example for FP. I just went through it for FPC by FPC. So FPC1, I've attached a CBD where to communicate with the patient sensitively about his beta blocker. Another CBD is attached on airway classifications and how physical signs will vary from patient to patient. I've attached a reflection involving an interesting case involving Section 3 of the Mental Health Act. So again, you can do these for all the behaviours, and it's sort of, one sec, I'll just hide that. Yeah, you can do all of those things, and essentially that's how you do the curriculum section. Here there's a PDP thing, so you have to do a PDP for each rotation and say if you've achieved it or not. Reflections, you can reflect on absolutely anything that's been interesting to you, anything that's you can reflect on a rotation. I think I did it here. I had a rotation covering ITU anaesthetics and palliative care. I reflected on it. I had an interesting case involving Fournier's gangrene. I reflected on that. So anything that you find interesting or that made you or sort of provoked your thinking, you can reflect on it, and you can map it to your curriculum. Here's the tab form. So again, I received 11 responses. You need 10. 2 consultants or trained GPs, 1 doctor senior than F2, 2 senior nurses, band 5 or above, and 2 allied health professionals or other team members such as physiotherapists, healthcare assistants, or pharmacists. Career planning section. So I am considering a career in radiology, so I created a form for that and mapped it to my curriculum. I think there is a curriculum objective about considering careers, so you can do that. You can actually link your HEE e-learning for health account to your Horus ePortfolio, and any hours you complete on that will map to this. I'd highly recommend doing that because then the deanery can see that you've been working on your e-learning. Okay, so all of these were essentially advised by the description. I'll go back to it. So if I go back to my curriculum, HEE e-learning for health. Show. Okay, and then if I click on e-learning, it is very finicky, guys. Here we go. So for the F1 behaviors for FPC1, here are all the e-learning modules they suggest you can complete and map to that curriculum objective. So anything on this list, Mental Health Act, Adverse Drug Effects, Nice IV Fluid Assessment, you complete any of these, you can map it to FPC1, and that counts as engaging with your curriculum. It's quite useful to know that because I didn't realise that until my very last rotation. So just be aware of that and be aware of the descriptors, which, if I can get it up. Yeah, be aware of the descriptors which go through everything. So FPC2, for example, recognises the need for urgent intervention to treat both mental and physical health problems, and so on. Clearly communicates finding of physical, psychological and social assessment, including any uncertainties to more senior doctors. So that would be a case where you've escalated to a senior, for example. You can log any concerns. I don't really have any concerns. I think there was some concern where I hadn't completed my tab, and in the end it was completed. I think I had 9 out of 10 completions by the end of my first rotation. You need 10. So there was a concern that I hadn't completed the tab, and so they asked me to extend my tab deadline and contact some consultants to get it done. So I spoke to some consultants I liked and asked them if they'd like to complete a tab for me, and one of them said yes, and got it. I got it done in the end. So yeah, that's a sort of whiz through my portfolio and how you can get things done. There is an ARCP form which they do at the end. Let's go to it. ARCP outcome. And that just shows if you've completed your thing. So for me, they said, excellent portfolio, well done, congrats on completing your FY1 year. No extra attendance required. And that was everything. Outcome 1, here are the outcomes you can have at the end of the year. So outcome 1, satisfactory completion. Outcome 3, inadequate progress, additional training time required. Outcome 4, which is the worst outcome, you're released from your training program. I think this would only come to light if you'd done something seriously unsafe. That would be investigated by the GMC. So that's very, very uncommon. Outcome 5, incomplete evidence presented. So yeah, I'll go back to my presentation and I'll just run through my top tips for you guys in summary. So complete your tab on your PSG first rotation. The last thing you want to do is go chasing after colleagues in your last rotation, trying to get signatures. It's very stressful. I had to do it for my PSG essentially, so I had to get my clinical supervisor to email a number of people to sign my PSG form because I couldn't send the emails in the PSG. And my clinical supervisor randomly sent it out to individuals within the team. And unfortunately, some of those individuals responded and gave me positive feedback. So everything was good on that end. Don't leave things to the last minute. If you have to map 100 things throughout the year, that equates to doing something at least every 3 days. The more you do at the start, the better. I spread it out generally across the year, and I wasn't stressed. So if you can do that, and you will have allocated portfolio time to work on your portfolios, I'd highly recommend doing that. Another top tip, FY2s cannot sign you off for SLEs. I'm not sure why this is. I think it's because in the past, FY2s have often been close friends with the FY1s and haven't sort of been assessing them properly or something. So it would need to be a minimum of a more senior SHO, so like an internal medicine trainee, core surgical trainee, specialty trainee, so forth, as a bare minimum. Start your audit or QIP early. The earlier you start, the better. You can complete your second cycle of your audit or QIP and present it locally, regionally, or nationally, which will get you more points for your specialty applications. The earlier you start, the better, because these things can often take ages to get going, ages to present, and ages to complete your second cycle. So start early and you'll be good. Again, it's your responsibility to arrange meetings with your clinical or educational supervisors. If you don't have any reply, chase the secretary. If the secretary is not really helpful, contact your foundation training program director, or I think it's contact your education department first, and they'll be able to help you. And lastly, of course, it's a shameless plug, but Mind the Bleep is an excellent resource for completing non-core teaching. You will receive a certificate of attendance following feedback, which will count for your non-core teaching hours. So I attended a number of teaching sessions on Mind the Bleep this year, and I counted all of them. Because I got a certificate for each of them, I counted them towards my non-core teaching hours, and that really helped fill the gap. So if you're struggling with things to do for your non-core teaching hours, if you've not got things like e-learning or seminars, online Zoom sessions via Mind the Bleep or via Medal, count for those. And so thanks for listening to my talk, guys. I'm just going to advertise our webinar series. As you all know, it's the FY1 Survival Guide webinar series. This is talk 5 of 10. We've got one on Friday covering FY1 Pay and Finances by Dr. Sarah Asher, who's a former accountant, very knowledgeable on pay and finances, understanding tax codes, extra pay, locum shift pay, and so forth. So I'd recommend tuning into that webinar if you've got time, just so you can have a better understanding of your payslip. My colleague Hamza, who's in the chat today, is delivering the talk on DNA CPR and verifying death. We've got myself delivering the talk on preparing for on-calls and common bleep scenarios. And we've got 2 medical registrars at our trust delivering the talk on managing the deteriorating patient. That'll be a really good one. It'll be a bit of a longer session, but I'd highly recommend coming to that session, because the last thing you want in F1 is to have a deteriorating patient and be panicking and unsure what to do. So they'll tell you when it's appropriate to escalate to your seniors, when it's appropriate to do certain things in terms of medications and examination findings and so forth. So that managing the deteriorating patient talk is going to be a good one to attend. And I think lastly, we do have a Prepare for FY1 course. It's free. It's identical courses, in-person courses in Liverpool, London and Sheffield. There's simulation-based small group teaching sessions with presenters with 5 years of experience. There's free lunch and dinner thanks to our sponsor, The Next Step. Last year, confidence in FY1s rose from 20% to 75%. It's almost sold out, so for more information, visit mindthebleep.com/FY1 course. And that's the end of my talk, guys. Here's a QR code for any feedback. I'll let Hamza come back into the talk and ask any questions.
Okay. Thank you for this insightful talk on the ePortfolio, Nihal. So now we'll start our Q&A session. Feel free to put questions in the chat and we'll ask Nihal about them. I've also posted the link for the feedback form where you'll get your certificate of attendance, and this can be used for your non-core teaching hour. So should we start with the first question, Nihal?
Yeah, sure.
Yeah. So one of our attendees, Hadia, she just wanted more clarification on what a mini-KEX was. She wasn't, yeah.
Right, let me share my screen. Share screen. Can you see my screen?
Yes, I can see it.
Right. Let's go to, I'll start a new form. This is the form section. I'll go on mini KEX, mini clinical examination exercise, and I'll create on start a new form. So here's what you need to do for a mini KEX. Date, title, provide a brief anonymous description to allow the mini KEX to be contextualized. Describe the setting. So was it in the community? Was it in an acute setting like ED? Here, the 5 categories you can put this mini KEX into. Is it a clinical assessment, a clinical prioritization, holistic planning, communication in care, or continuity of care? These are things that the trainer fills in, and this is something you reflect on. So, for me, I think it has to be observed, anything you do. So if I'm clerking a patient in, and I'm assessing them, taking history, examining, seeing what we need to do for them, that's a clinical assessment. I would log that in the clinical assessment section and log it as a mini KEX and get a senior to sign it, as long as they've been with me while I'm clerking. Likewise for holistic planning, if I've seen a psychiatric patient, for example, and I'm thinking they need some mental health input, or maybe they need to be sectioned, I don't know. So I would potentially liaise with a psychiatrist and discuss would they need to be sectioned. If they did, I could log that in the holistic planning section, and that would be an holistic approach to care, because you're considering other things as opposed to just physical health. You're considering mental needs. You can be considering social needs. So any interaction with any healthcare professional, like a social worker, like a mental health professional, that could be done or used for the holistic planning section. Again, communication and care. If you've, for example, broken bad news to a patient with supervision, that can be logged in the communication and care section. as long as it's been observed. So, make of that what you will, but there's a number of things you can log as a mini KEX. It's not a set rule. It's sort of anything that's observed within the workplace. As long as it fits into one of those categories, that would count as a mini KEX. And the trainer would feedback and agree an action for you to work on. And these are the people you can nominate as trainers: GPs, consultants. Again, like I said, ST or CT1 to 2s as a minimum, SAS doctors who are just before consultants, or considered the equivalent of consultants, or even a pharmacist, okay? So that's a mini KEX. Does that clarify things?
Yeah, I think so.
Perfect.
We have another question from Sama. So she would like to know whether mandatory modules you do prior to induction, does that count towards your teaching hours?
It does. I used it. It does count.
Okay. All right.
Yeah.
Because I was under the impression we couldn't use it, but if you manage to use it, then yeah.
Mandatory teaching. So it's e-learning modules, isn't it?
Yeah, the one we do before starting work.
Yeah, so if you've done it a week or two prior to starting, that's absolutely fine. You can log it within that rotation. So I think before we started work, we had to complete learning on equality and diversity. We had to complete work on safeguarding. I logged that and mapped that to my curriculum, and there were no issues from my end. So I think it might vary from trust to trust or deanery to deanery, but probably check that with your deanery before you do it. But it worked for me.
Oh, that's good to know. All right. Sorry, Sama. So you can actually use it to put on your portfolio then. So someone was asking, Christy was asking, is the multi-source feedback recorded in the portfolio as well? I think she meant the tab. So
That's
it would
the
be
same.
under the tab.
Yeah. That's the same thing as the tab. So that would be recorded.
Another question we have, can we upload any teaching or evidence of attending any teaching you've done as part of 5th year of medical school on your portfolio?
That can't be included. No, it has to be within the foundation year 1.
Yeah.
Yeah. I think it's not a hard rule, but like with the e-learning stuff, you can do it if you've done it a few weeks before FY1, because you've done it and there's no point in doing it again during the rotation. But if it's in your final year of medical school, that's not the same as doing it in FY1, so you can't use that.
Yeah. Can we do DOPS procedures which are specific to specialties such as intubation to demonstrate interest in anesthetics? And will those help for specialty applications?
So you can do DOPSs with senior guidance. If it's something like intubation, you will have to be supervised by a senior as an F1. You get it signed off. Can it be used for specialty applications? No, but that doesn't mean you shouldn't do it. Especially if you're interested in anesthetics, you want to be intubating as many patients as possible, gaining the experience if you're able to. So if someone is giving you the opportunity to do procedures and you're interested in that specialty, go for it. Okay.
Yeah. And someone has also asked, how do we get our supervisors to sign for a mini KEX, CBD, or DOPS?
So here, I'll share my screen again. Okay. Here. So I would nominate my trainer, and here you put in their name. If they are trained in providing feedback, their email will come up and it will send them an email automatically. So they have to reply via email. It's not something that's done on paper format. It's done via email. Everything is done via email.
It's also good just to send them a reminder or remind them in person, because a lot of the time the supervisors will get a lot of email and they might forget about signing it. Priyankaran has asked, if there is some negative feedback you've received during a CBD, should you log it in on your portfolio, and will this affect your ARCP?
So if there's negative feedback on a CBD, it depends. There wouldn't often be most of the time. Seniors are constructive in their feedback, so they give constructive feedback, and the agreed action is normally something that's very reasonable. If it's sort of negative, you know, any sort of, I think the things you have to declare on your ARCP are things like complaints or any concerns. So negative feedback isn't really something you declare for your ARCP. But equally, if you sent someone a CBD and they've said something negative on it about your performance and sent it back, that's logged on the system. From what I understand, you can't delete it. Is that true, Hamza?
Yeah, that's right.
Yeah. So if they do give you negative feedback, you've already sent them the CBD. They filled in the negative feedback and sent it to you and uploaded it on the system automatically, and you can't delete that entry. So
Yeah.
it's not something you declare on the Form R. It'd just be on your portfolio for people to view. But I'm sure that will not be the case. Most seniors are very helpful and they won't do things like that.
Yeah,
People
I agree
understand
with
that
Nihal.
FY1s are very junior and they try and be supportive.
It'll mostly be constructive feedback, constructive criticism, and let's say if you've not done it as well or to the standards, most seniors will just tell you, don't upload it, just do a few more before you can log it onto your portfolio. Uh, Marzan has asked, can an audit done in final year of medical school count towards the portfolio?
I don't think it can. Hamza, can you clarify on that?
Yeah, so it wouldn't really count, although it depends on the circumstance again. So for me, it kind of counted. So if you've done the audit, but then presented it at a conference later on during your FY1 year, then you can log it onto your portfolio. But if it's just an audit done in final year and you've completed the audit in final year, then it wouldn't really count because a portfolio is for things done during the FY1 year. Your supervisors want to see what you've done during this 1 year. They don't want to go back and see what you've done in medical school. We have a few more questions. Other than signatures, what other types of evidence does a portfolio need?
So, any certificates. So, for example, if you do departmental teaching, they'll most likely give you a certificate, which you would then log as formal, and then you get some feedback as well, and you log as formal feedback. What other things like signed letters or just letters don't have to be signed. You'd log those. Most things are for SLEs. Any SLE, you send it to the senior, and they will fill it in and return it back to you, and that's what counts as the signature. So other types of evidence, like we've discussed, are reflections, teaching, teaching, and then your SLEs, which are signed. So that's about it. Do you think there's anything to add to that, Hamza? Oh, I think Hamza has exited the call accidentally. Right. Is he back with us? One second, guys. Hamza, are you back with us? I'll carry on answering the question. So, can you clarify what mapping is? Mapping is essentially linking. So you're linking your you're linking your achievements or your forms to the curriculum objectives. That's what mapping is. Everything you do, you can map it. You can map it to more than one thing. So I've completed a CBD on a patient with, like I said before, psychiatric issues. That can be mapped to multiple points of the FPC curriculum or linked, and you have to map at least 10 things to each. Not at least 10 things, maximum of 10 things to each of those links.
Yeah, sorry.
It's fine. Are you back with us now?
Yeah, I'm back with you.
Some technical issues.
Yeah, my internet connection is not the best, fortunately.
It's fine because you're not presenting. But yeah, let's. I think we're just on the last question, Hamza, from Hadir Ishmael, and I'll just read it. So, is it better to inform consultants beforehand that you would like to ask them for signatures, or is after better? So, a lot of them would say yes if you ask them afterwards, but some of them are not very happy if you ask them afterwards. So, for example, in my case, I was on call once during a medical on call. Myself and one of the consultants completed a case. We discussed the case, history examination findings, blood test results, etc. I then asked the senior, am I okay to fill this in as a CBD or send you this in as a CBD? And his response was no. So it does vary from senior to senior. He said to me, if you want it to be done as a CBD, you have to introduce it at the start of the presentation of the patient. So just to be on the safe side, I would just say to the senior, look, I'm going to present this patient to you, but can we do it as a CBD? And most of them would be very happy to do so. Another question from Mazen Khan. Hamza, I'll let you answer that one.
So are there any previous Mind the Bleep talks available to watch? So yeah, there's the YouTube channel where we'll be posting recorded versions of our webinar, including this one. But there are also other talks given in previous years by other speakers, which can be quite useful for FY1. So I'd encourage you guys to visit the YouTube channel.
Any more questions, guys?
I'll just post a link for the feedback form in the chat as well, so don't forget to fill out those feedback forms.
Thank you, guys. Any last questions?
No, I think that's it.
Great. Should we call it a day, Hamza?
Yeah, we should. Thank you, Nihal, for your talk. And thank you for attending,
Hamza.
guys.
Thanks, guys. See you later. Bye.